Okay. Kalimera, dear colleagues, dear chairman, it's so nice to be here. Thank you for invitation to this great event, because a lot of time was in your country. I really love your country, but only for vacation. And now I'm here to share with you my experience and our experience of our center and whole team in treatment patient with cardiomyopathy and using AcuSync system device and study CoSync heart failure study. And it's my disclosure. And you know that despite optimal medical therapy and resynchronization therapy, MitraClip device, patients sometimes need some new devices to reduce dilated left ventricular, and sometimes we need to win some time before transplantation, patient who waiting for transplantation or implantation of left ventricular assistant device. In our center, we perform about 50 transplantation of the heart per year. And this new device is transcatheter device to treat dilated left ventricular, and reduction size of left ventricular, and reduction of left ventricular wall stress. And that's why initiate a biological reverse remodeling. And I can see you a short video how device goes to the left ventricular under the mitral valve and on the free wall of left ventricular behind the heart, and then stitching this left ventricular. And that's why we have such kind of the advantages. And on this floor, you can see green light after stitching of left ventricular and purple line before procedure. And we can see acute reduction of left ventricular in 8.7 millimeters. And then we can see during the follow-ups biological reverse remodeling during 12 months of observation. It's CT from our patients, 3D CT. You can see left ventricular before and after the implantation of 12 months of observation. And now it's a nice slide how device AcuSync integrated into the tissue of left ventricular. On the this slide we can see we can see device integrated just immediately after the implantation. And on next slide we can see 10 days after the implantation, and last one at 90 days after implantation. It's picture from our center, because this patient went to the transplantation of the heart due to arrhythmia, and that's why we can such nice picture when AcuSync integrated into tissue of left ventricle. And we published our 12 months outcomes in journal last year, when we can see progressive reverse remodeling and improvement in quality of life and functional capacity. But now I would like to speak about 24 months outcome with these patients. It's the first time we speak about 24 months outcome. And here we can see 51 patients with most of all with non-ischemic cardiomyopathy, with some implantable device, ICT, CRT. And we understand that this device not influence so much on the mitral regurgitation. That's why we include here patients without significant mitral regurgitation, with dilated left ventricular and ejection fraction about 30%. And we haven't serious complication, just access-related complication, one tamponade and one stroke, but it's possibly related to the procedure because it happened in our center 7 days after the implantation of device. And during this period of follow-up, we can see a reduction significantly in left ventricular diameters and volumes here, and increasing ejection fraction as well as quality of life and functional capacity. And that's why we have survival 90% and 2 years. Unfortunately, we have 5 deaths, and 3 deaths were suddenly deaths. It's not due to decompensation of heart failure. One due to cancer, and one death was due to decompensation of heart failure, and 3 implantation of left ventricular assistant device. We can see a reduction of hospitalization during this period of follow-up, significantly reduction in hospitalization. And now we involved in new investigation, COSINCH heart failure study. It's investigation, it's randomized investigation with patient ischemic and not ischemic cardiomyopathy, with patient with ejection fraction 20-40%, dilated left ventricular, and as I told, without significant mitral regurgitation, and we can involve a patient who was implanted with mitral clip, because we understand now that this device, mitral clip device, influence of valve of mitral regurgitation, but unfortunately not significantly influence on dilation of left ventricular. And this device, a COSINCH device, we can use to reduce left ventricular, but unfortunately it's not influence on mitral valve. That's why it can be used together. And now in this study involved 100 sites. It's the Netherlands, Germany, Czech Republic, Italy, France, Belarus, and Lithuania, and 3 sites from your country will take part in this investigation. We can see on the map, and more than 160 patients approved to randomize. And in our center, in this study, we approved to randomize about 65 patients. And now I would like finally to speak about our result of our center, because we have observation follow-up about 4 years. But here result of 2 years of follow-up, and we can see significantly reduction, acute reduction in the left ventricular volume and diameters. And then we can see on the graph dynamic of indexes. It's biological reverse remodeling during the 24 years of follow-up. On the picture we can see TE pre-procedure and after the procedure, and 3D TE during the procedure, just to show this device. And we also can see increasing in left ventricular ejection fraction and decreasing pro-BNP. Unfortunately, not statistically significant, but we can see the big variation, and number of patients that we included was 23. That's why, but not so significant, but it's, you can see good tendency of decreasing of these parameters. And one of the best candidate for this procedure, it's a patient who has ejection fraction 26% and volume and diastolic volume about 237. And we can see in follow-up 24 months really increasing in ejection fraction till 49%. It's a bridge to recovery. But sometimes we use this device in patients as a bridge to transplantation, because in our experience for 4 years, only one patient came to the transplantation of the heart. And that's why this device, acoustic ventricular restoration system, treats ischemic and not ischemic cardiomyopathy in patients with reduced ejection fraction without severe mitral or tricuspid regurgitation who remain symptomatic despite optimal medical therapy. And early clinical results demonstrate acute reverse remodeling and biological remodeling and protected or further dilatation of the left ventricle. I think it's one of the most important things of this device, to protect or further dilatation. The acoustic ventricle restoration system could be used to restore hemodynamic function of left ventricle in patients with moderate dilatation and with severe dilatation, as I told, as a bridge to heart transplantation. And result from our early clinical studies in patients with reduced ejection fraction demonstrate a favorable safety profile as well as significant improvement and reverse remodeling and increasing volumes and decreasing volumes and increasing ejection fraction and in quality of life, functional capacity, and heart failure hospitalization. And randomized controlled study is currently underway to assess clinical safety and efficacy of the acoustic system in patients with reduced ejection fraction. And your center will take part in this investigation too. And I'm proud of our team, and thank you for your attention.
Thank you very much. Very interesting approach, very interesting intervention. As we were discussing earlier on, it's very important for low donation environment like ours, actually, because I realized that it delays the progress of heart failure. I realized that if we have got mitral regurgitation, severe mitral regurgitation, we have first to repair the mitral valve and then to carry on with this system, isn't it?
Yeah.
Vice versa?
Yes, we can use it's worse, but in the first investigation, we include patients with severe mitral regurgitation, but unfortunately, if we have a degree about 4, it's not influenced, but we can involved patients with degree 2 or maybe 3 with not big volume. The volume of regurgitation about 25 till 30, not more. But if we have regurgitation about 40, 50 milliliters mitral regurgitation, the first step, I think we have to use mitral clip, but unfortunately mitral clip, according to our experience, we have about 100 implantations of mitral clip system, and we can see if it's functional mitral regurgitation, mitral clip don't influence on big dilated left ventricular. It's influence only on the valve, and then we can use something else to reduce diameter of and volume and protect of further dilatation.
Right.
And then, congratulations, it was an excellent presentation. Have you identified any markers of successful implantation? Do you have any BNP kind of markers?
Yeah, we use pro-BNP markers, and you can see really decreasing of pro-BNP markers during our investigation, and in all patients, we can see improvement in pro-BNP marker as that's quality of life and our parameter of left ventricular, not another one markers, just pro-BNP.
And if there are structural changes in the right heart, if you have pulmonary hypertension,
no, we are not include. I see. We are not include patient who has pulmonary hypertension more than 70 milliliters, just not so severe, because we cannot treat this one with this device.
Roxana?
Congratulations on your work. It really is intriguing. to see possibilities of this device. I guess one question that I have, in what way are you disrupting with the implantation, the mitral valve apparatus? Because it seems to me you're coming from below and then you're going somewhere close to the mitral valve, but not quite in the mitral valve. But the apparatus, as you know, is much more complex. Is there disruption? Have you seen anything like that where the apparatus, the chordae, get in the way when you're implanting this device?
We are not disturb mitral valve because we are going through aorta valve, and everything that we made with TEE, and it's situated about 12 millimeters under the mitral valve. That's why it's not disrupting, but sometimes we can see during the procedure severe mitral regurgitation, but it's during the procedure before cinching, and when we stop cinching and device go back, it's disappears this regurgitation. Sometimes we can see arrhythmia, and sometimes in 3 patients we can see bundle branch block after the procedure. But in some days it's disappeared. And we have experience with implantation 35 patients, and we needed 3 CRT implantation in 10 days after the implantation of this device. Because before procedure, they have temporary bundle branch block. And after the procedure, it was permanent, and we have to implant this device, new device.
I'm sorry, but I'm just continuing, and it's just really in order to understand. The apparatus goes down up to the papillary muscle, which is very, very low. So there is no way that you do not touch it or disturb in any way with the action of the apparatus. You understand? We're asking just in order to understand. Maybe this is part of the treatment, but there is no way that it is just holding it without influencing in any way on the apparatus.
You know, maybe you can go back and show us that slide with a procedure so we can discuss while people can see.
No, I think it's intriguing. It seems to me you go, from what I saw, that you bring it in, but you go around the apparatus. You try to go around the apparatus.
Behind the heart.
And behind it like that, because it's like like a snake. It goes around and then you cinch it. But it could have those important, so it seems to me you really need very, very good transesophageal echo to watch the procedure. But maybe you can show it, because that would be helpful.
Before procedure, we made CT to really understand. Before CT, before procedure, we made CT to really understand how possible we can go. And we know about hearts, we know about everything, about structure of mitral valve, about hearts, and during this procedure we make TEE to really understand how catheter goes. Because I perform TE2 during the whole procedure, and it's the most important moment of the whole procedure when you go behind the hearts. But previously we can see all structures on CT, and we discuss with proctors where we have to have big attention to what point. Because in P2 and P3, sometimes it's additional heart. That's why we have to go very closely to the left ventricular free wall and really behind the heart. And if we have not suitable structure for implantation, we reject such kind of the patient. It's if a lot of hearts and we cannot go forward.
Is there a way to use MRI before to see the chords a bit better?
CT.
And any role for utilization of intracardiac echo in addition to
Yes,
TE? That could it help? I mean, we're going to have a similar session right after about the tricuspid valve, but over here, maybe ICE also might help?
We use only TEE, esophageal echo, during the whole procedure. Yeah, before procedure, during the procedure, during this important moment, and after the procedure. It's the same technology of using TEE as implantation of mitral clip. But according to my experience, mitral clip is more difficult for me, our specialist, when we do TEE during the procedure. It's more simpler.
Okay, I think this is very interesting. And another thing, it looks pretty standardized, the procedure, right? Yeah. So we did the animal training. We were looking to overcome some bureaucratic hurdles that we have in the introduction of the study in Greece, but it looks standardized. And in your opinion, what's the learning curve? You know, how many cases does an operator need to have in order to be capable in doing this procedure? So it's 220?
How many cases?
Yes.
I think it depends how often you do this procedure. Yes. For example, if you do one procedure per month, it's not enough. Yes. Sometimes we did, for example, during the week, one procedure per day, to be more to have such experience. And now we perform 35 procedures, as I told, and I think that operator now it's enough can do this procedure in future, and now he is a proctor. Yeah,
because you have in our centers, the transplantation center, and the Dr. Adamopoulos and his team, and Dr. Bonius, as I see here, he's our heart failure specialist. They are doing the best they can. Transplantation capability in Greece, we don't have a lot of donors. So maybe as a bridge to therapy, and you give ARNIs, you give SGLT2s, inhibitors, and maybe you cannot do anything more than that. So maybe it's a solution. We have to figure it out.
We really need interventions to delay the heart failure progress, actually.
I think that's very important.
Okay.
Now, one final question is, you talked to us about how many cases the procedure has to do. How many cases does a TE specialist need in order to help with the imaging of the cords and all these things? I mean, that's also another level of expertise that you need to have. So
but if
it's easy, let's say a TE person who is used to mitral valve interventions, mitral clip, this no problem to do this right away, or they need some special training to obtain some special views, etc., for this imaging?
Yeah, it's not big training, but if person perform TE during the mitral clip procedure, it's not difficult to start to do this procedure. But you have to use some additional view, transgastric view. We don't use this transgastric view during the mitral valve procedure. But if you make tricuspid valve procedure, it's really more simpler.
Good. So, thank you.
Okay, thank you very much.
Thank you.